So welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database, the Quality Improvement Series, Reducing Readmission Rates. Today is Friday Eve, Thursday, April the 24th. So thanks everyone for joining today. Small group with us today on the call for the STS side of things. It's just myself and Nancy Honeycutt from the Adult Cardiac Surgery Database side. We have Emily Conrad, our fierce leader, Carol Crone, and our general thoracic consultant, Ruth Raleigh. Today is going to be the Ruth Raleigh show. So I do not have any updates or anything from the STS side of things. So I'm just going to turn things over to Ruth. We do have a few polling questions for you today. So just if you would mind, we would greatly appreciate you responding to these polls. And so with that, I'm going to turn things over to you, Ruth.
Perfect. Is my audio okay, Leanne?
It's perfect.
Okay. So if you want to click over to the next slide, we're going to start by sort of recapping sort of where we've been, where we're going, sort of set direction for some of the future meetings for this quality improvement series. I felt like we've been in this for a little while now and just kind of wanted to see where we've been, see where we're going. So we had talked in the initial webinar about how we do quality improvement projects, and we really follow these 5 steps. The first step of which was to define our goal, which was to nationally decrease readmission rates for lung cancer patients. If you want to click to the next slide, Leanne. So again, just recapping readmission rates. Why do we care? We've already gone through this content, so I'm not going to belabor it, but patients who are readmitted generally tend not to do as well for a lot of reasons. It's difficult physically, emotionally, psychologically. And then health systems are often challenged as well by patients who are readmitted. I'm going to go to the next slide. The next phase of our quality improvement project was to measure our baseline data. So if you want to click through the next couple of slides, Leanne, this is the same baseline data that we've already reviewed. I just wanted to pull it forward into this slide deck. We separated recall sites by the number of records that they had submitted with readmission and complication rates because the two are linked. If you do not know your de-identified site ID, I'm happy to provide that to you. Just let me know and I will get it to you for those of you who have not yet received it. You want to go through the next couple of slides. It's just the different sites or different cohorts of sites based on the number of records. You can see up there at the top when you review these slides again later and sort of place where you are in these cohorted data sets. So this was measured, this is the baseline data. So my first question is, have you had the opportunity to review your baseline data with your surgeons in the context of this QIF project? Yes or no? I can't see the polling data, Leanne, so whenever you feel like we've got most of the responses, feel free to.
Okay. Yeah, we are, I think we're starting to slow down. So I'm going to go ahead and end it. So, and I share the results. Are you able to see them, Ruth? If not, we're at 28% said yes, they have shared. And then we're at 72% have not.
So for the sites that haven't yet had an opportunity to review the baseline data with their surgeons, I would highly recommend that as one of the first phases of this process that you make time to do that with your surgeons. If you want to go to the next polling question, Leanne, I think one of the other things that you can do at that meeting is to engage with institutional stakeholders beyond your surgeons. So just curious to see how many sites have had the opportunity to engage in other institutional stakeholders besides the surgeons. People could answer this one, yes or no.
We're starting to slow down. So I'm gonna go ahead and stop this one. As soon as I say that, every time the number goes up. Okay, gonna go ahead and end the poll. And so we have 21% yes and 79% no.
Okay. So when you set up time to meet with your surgeons, I think one of the things that you can talk through with your surgeon is if they're aware of other stakeholders that need to be pulled into this quality improvement project for your institution. They sometimes have connections with chief quality officers or quality program leaders. I'm sure that they've all been involved, even peripherally in other quality improvement projects at your institution, and have some ideas on other resources that can be involved. Certainly, it's going to be challenging to bend readmission rates without other stakeholders being pulled into the project for opinions. Okay, if you want to go to the next slide.
Yes.
Okay, so this is sort of where we're at now. So in this 5-step quality improvement process, we're sort of straddling the analyze and improvement phases. So for the analyze phase, our goal is to use your STS harvest reports to implement processes at each of your sites to decrease readmission rates. We'll provide education and support for the process. So one of the things that we had the opportunity to learn from was Dr. Brown's presentation. I think that was in February is my recollection. That recording is online. If you weren't able to be at that webinar, I would highly encourage you to listen to Dr. Brown's presentation. We hope to have additional presenters in the future, which is part of the sort of analyze improvement phases. But when we think about how we can affect change, I think one of the things that would be really helpful at this point in this process, this quality improvement process that we're undertaking together, is perhaps to narrow our scope just a little bit. So if you want to click to the next slide, Leanne. So if we look at this paper that was published by the Michigan Society of Thoracic and Cardiovascular Surgeons Quality Collaborative, it talks through the various factors that they evaluated that could potentially or not potentially be linked to readmission after a lobectomy. Now, I recognize our patient population is a little bit different because we wanted to be able to use the STS dashboards. And so we're doing lung resection, which is, of course, by nature, just a little bit different than the lobectomy population. But sort of as a surrogate, we're going to use this data just for simplicity of the project. So if you want to click through to the next slide, Leanne. These are some of the variables that were identified in that paper as being significant for readmission after lobectomy. So patients that returned to the OR were coded as positive for sepsis, had a pleural effusion or pneumothorax requiring intervention, had a central neurological event, an air leak greater than 5 days, or atrial arrhythmia requiring treatment. So if you go back up to the previous slide, you can sort of see, so like if you look at central neurological event, which is about midway through that screen, you can see that blue bar is pretty far to the right, indicating that there was significance for that variable in terms of patients likely being readmitted. It's a great paper. If you haven't had a chance to read it yet, I highly encourage you to do so. So my next question for the group, if you want to click forward 2 slides, I'm sorry, Leanne, I feel like I have you like clicking slides right and left.
I'm happy to
drive.
drive. Happy to drive. And I just realized I'm on camera, which is awful.
Oh, my first question is, what do we want to tackle together as a group? So if you think about your individual sites, what would your sites find valuable for us to do some focused, targeted education and sharing amongst different hospitals? What would really be the most helpful? So A is return to OR, B is sepsis, C is pleural effusion or pneumothorax requiring chest tube, D is central neurological event, E is air leak greater than 5 days, F is atrial arrhythmia requiring treatment. Obviously, frequency of these postoperative events is extremely variable. Central neurological events are relatively low frequency, but obviously have a usually quite a significant impact on the patient's outcomes. So I'm just curious to see, where the group lies, like what would be a helpful next next targeted teaching point or point of collaboration, I guess.
Let's see here. We've still got some responses coming in, Ruth, right now. Let's see, we've got a little bit of everything. Mainly early greater than 5 days is taking, we're at about 47% of those that have responded. So this is great information. This is let us know where we want to take this. Okay, I think I'm going to go ahead and end it. So can you see the results, Ruth? I'm sorry, I can't remember what you said.
I can,
So,
yep. So
okay.
early greater than 5 days is at 49%. The second runner up was pleural effusion or pneumothorax requiring chest tube at 20%. So it's really helpful. We'll pull together some targeted sessions on how different sites have reduced their air leak rates, with the hope that we can impact air leak rates at other institutions and then see that sort of reduce overall length of readmission rates without hopefully increasing length of stay. So we'll keep track of those variables. If you want to go to the next slide. As I mentioned, Dr. Brown shared her presentation back in February. We'd love to have other site leaders who have already accomplished decreased readmission rates, or as we just mentioned, have done quality improvement projects related to air leaks present. And so my next question for the group is, if you want to go to the next one, drum roll, please, Leanne.
Sorry, there we go.
No, would your site be willing to present interventions targeting readmission rates and or air leak rates? Just curious how much interest we have within the group and attendance in putting together a presentation.
Yeah, we really appreciate having other people, because I know you all get tired of listening to Ruth and myself, and it's just so helpful if you can help present and share and collaborate, what you're doing at your institution and help your colleagues. And it's really, what this quality improvement series is about, having other institutions share and learning from each other. So it would be greatly appreciated. So far, we have one person, or yeah, that's willing to present. Which we will take it. All right, Ruth, that's about all we can get. That's all.
Okay.
We're really not scary, I promise.
If you are the person interested in presenting, please send Leanne or I an email and we'll set a date for you to do your presentation. It doesn't have to be next month. We'll give you as much time as you need to pull that together and are happy to help in any way that we can.
Yeah, absolutely.
Okay, we want to go to the next slide. So just a reminder, what is our goal with this? Our goals with this project, as Leanne just mentioned, we are really hoping to show the value of the database outside of just getting reports and now not really star ratings, I guess. They're like not star ratings. We love working together as a team. We love making this data actionable. This data is really meaningful for our patients already. This is just another way to add value to this data for the patients that we all are so happy to serve. And we'd love to decrease the cost while providing incredible high quality care to patients we serve. If you want to go to the next slide. So now time for open discussion. Please use the Q&A function. We'll answer as many questions as we can. I see that we have one question in the Q&A box already, which is, who would that include? The other stakeholders. So the other stakeholders, generally, hospitals will have entire quality improvement departments quite often. You may find that there's an entire like organizational structure that sits there. So like the thoracic surgery data lives within surgical data, which lives within other quality improvement infrastructure. I would say if you have, depending on what your intervention is, you might need to include your respiratory therapists or your ICU nursing team or your progressive care unit nursing team, your daily rounding physicians, your intensivists. It really depends on what intervention you're trying to implement, but you really need to think about that patient and that process from like A to Z. Maybe there's something going on in the OR proper that might be a source for a postoperative event, and so really think through all of that. There's another question. Who do I email for my site number on this graph? Ruth, yes, I'm happy to send you your site ID participant number. It's not your STS participant ID because I wanted it to be truly anonymous. So I'm the only person that has the key to that data set. So if you email me, I'm happy to give it to you.
Yeah, I put, you should be able to see, I responded to the email, but Ruth can be reached at rraleigh@sts.org, and I'll put her email in the chat as well. I don't, like Ruth said, I don't have the key, but I know if you want to share that with me, Ruth, I can also help disseminate some of the emails and
Sure, no problem.
yes, happy to help. Let's see here. A couple of questions. Okay, no. Sandra wants to know if she can ask an abstraction question today. I defer to you, Ruth. I know this is mainly our QI webinar, but I know you probably don't have the training manual up or anything, but if you prefer just an email, it's totally up to you.
I'll do my best. I don't have the training manual. I'm actually leading this webinar from an airport today. So it's very exciting. I apologize if you guys can hear the overhead noise, but I'll give it my best shot. Sonia, what's your question?
So if you'd rather raise your hand and just ask it, Sonia, if that's easier, you're more than welcome to do that. Yeah, hold on. Okay, you should be unmuted. You might just have to unmute yourself when you're in, Sonia. It looks like you're still muted. Oh, there you go.
Okay, can you hear me?
Yes, ma'am.
Okay, thank you so much. So I have a case. It's in chart. It says a 2.5 centimeters right lower lobe carcinoma, and then there's a 1.9 centimeters right middle lobe. So I was just confused because if I look at the training manual, this would be a T4, right? But the nurse practitioner charted T1C and T1B in a chart. So what should I do?
You should follow what is in your medical record. So basically what your nurse practitioner is saying is that your patient has two synchronous primary diseases, like two synchronous tumors, like two cancers growing at the same time. It's not that you had a primary in the right lower lobe that metastasized to the right middle lobe, making it a higher stage cancer. They're two lower stage cancers that just happen to occur at the same time.
Okay. Also, if we are using HeartBase for our to send the data to STS. So HeartBase has a upper lobe, lower lobe, middle lobe, and unspecified. If none of those, it's equals what is in my chart. If I choose other and then enter diagnosis manually, is that going to be okay? Is STS going to be able to pull it as a lung cancer, and is that going to get analyzed? Or does it have to specifically say what's in a HeartBase, lung cancer, upper, lower, or middle lobe?
It needs to be it needs to correspond to what the STS options are if you want it to be analyzed. So if you look at the document in the IQVIA library, it'll tell you what cases will be included in analysis. Anything that's not on that list will get tossed out.
Okay, makes sense. That's what I thought. I just wanted to double check.
Yeah.
Thank you. Thank you so much.
Yeah, you're welcome. Yeah, you're so welcome. Okay, any other questions related to the QI project? If not, I'm hoping to have a guest presenter, surgeon next month. And then we'll start working through some targeted monthly sessions on Air Leak. So that should be great.
I apologize.
Are you there?
No,
I'm here. Sorry,
Okay.
guys. All right.
I
Any
think we're,
other?
no,
Yeah.
I think we're just wrapping up.
Okay, thank you. Sorry. I have some workers here at my house and I had to step away for a hot second that lasted a little bit longer than I anticipated, so I apologize, everyone. All right, well, I guess that's it for today. Our next upcoming webinars, our next monthly webinar is scheduled for May 14th at 2:30, followed up by our June 14th monthly at 2:30 Eastern. And then our next quality improvement series webinars, again, will on May 29th at 3 Eastern and June 26th at 3 Eastern. Contact information here. Again, if you need to reach us, feel free to just shoot us an email, and that is all that I have.
Awesome. Thank you, everyone. If anyone needs help with their QI project, please send me an email. I'm happy to help.
Thanks, everyone. Thank you, Ruth. I appreciate you taking one for the team and doing this from the airport. I appreciate it.
No problem.
All right, sorry, everyone. Thank you, guys.